Welcome, everyone, to the COVID-19 Town Hall. This is our live forum where our presenters will speak directly to topics related to the COVID-19 pandemic and how our industry has responded. After each presentation, you will have an opportunity to submit questions into the app chat feature, and we will answer these questions live. Let's get started. Dr. Kyle Annan is an assistant professor at the University of Colorado Department of Pathology and the medical director of the Transfusion Services and Patient Blood Management Program for Children's Hospital, Colorado. She received her medical degree from the Chicago Osteopathic College of Medicine and did a pathology residency at Northwestern Chicago. And her transfusion medicine training was at the Blood Center of Wisconsin. At Children's Hospital in Colorado, her team successfully developed the first convalescent plasma collection program for the state of Colorado. Dr. Annan is experienced in pediatric transfusion medicine and therapeutic apheresis and has been invited to national meetings such as AABB, ASCP, and now South Central to present on her expertise. She was an honoree for ASCP's 40 Under 40 in 2018 and was recently profiled as a U.S. News and World Report hospital hero. Please welcome Dr. Kyle Annan.
Hi, thank you so much for that lovely introduction, Dr. Bryant. Sorry, I'm just trying to change my window here. There we go. Sorry about that. All right. So I was invited to talk a little bit about starting the convalescent plasma program here at Children's Hospital, Colorado. So next slide, please. So today I'd like to talk about the eligibility requirements for blood donors to be eligible for convalescent plasma donation. I'm going to talk about some of the early challenges that we needed to address when evaluating a process for convalescent plasma collection, and then discuss the recent published research on donor factors in particular that impact the efficacy of convalescent plasma for the recipient. So convalescent plasma has been all over the news lately, so it's not a mystery that much as to what it is, although we get questions all the time about what it is and what it really means. Convalescent plasma is just normal, regular plasma that just happens to have been collected from someone who recently recovered from COVID-19. And so the idea behind this is that this donor will have antibodies, predominantly IgG, from their recovery, and we will be able to collect those antibodies and then transfuse them into someone who's currently ill. And the idea is that antibody, having developed a specificity for the virus, will then be able to neutralize some of the virus and help the recipient on their way to recovery. And this is actually not a new idea. This has been used for a long time. Actually, it was originally developed in the late 1800s with the and then it was also used in the 1918 Spanish flu. And more recently, it's been tried in other viral entities such as MERS, Ebola. It didn't really take off for Ebola, but thankfully Ebola didn't spread that much because that one's particularly terrible, and H1N1. And I did quote one study here that looked at, it was a very small study. It was a randomized controlled trial. It was around 100 patients. And they looked at convalescent plasma treatment in patients who had H1N1. And they reported that it did work. Although, of course, being a very small study, it was hard to be definitive as to its effectiveness, but that was a randomized controlled trial. Next slide, please. So since the beginning of COVID-19, of course, it started in China, and we did get a few plasma fairly early on. So this study came out in the Journal of the American Medical Association, and this was treatment of 5 critically ill patients with COVID-19. And so this was just a case series, just reported that they gave it to 5 patients. So these were 5 critically ill patients who had COVID-19 and acute respiratory distress syndrome. They were all on ventilators. And they received CCP with antibody-specific binding titers greater than 1 to 1,000. And I'm going to mention the antibodies here a few times, and so remember that that was a pretty high titer. And then it was administered between 10 and 22 days of admission. And then after the convalescent plasma, they noted that body temperature normalized within 3 days of 4 of the 5 patients. And that they, within 12 days, their ventilator settings were able to be decreased, meaning their lungs were able to manage better on their own. Their viral loads decreased. They actually did measure those. And then all of the patients survived. So, I mean, that's a good start, but 5 case reports does not prove anything, really. So the next study that came out of China was this study that was a case control study. So this one was actually 10 patients who received convalescent plasma, and they had antibody titers of at least 640. And they reported that clinical symptoms were significantly improved in 3 days, including increased oxyhemoglobin saturation. And then 7 of the patients had undetectable viral loads within a week. All 10 patients were improved and 3 were discharged. And so, as I said, it was a control. So they did historical controls where they matched these patients by age, gender, that sort of thing. And that control group had 3 deaths, 6 were stabilized, and 1 improved. So, I mean, that's pretty dramatic difference if you think about it. But again, it's not our gold standard, which is a randomized controlled trial. But both of these studies at least suggested that there was some benefit to convalescent plasma. And it might be worth pursuing more. Next slide, please. So you might be wondering why a pediatric hospital got involved in convalescent plasma collection. So Children's Hospital Colorado, one of the things that I feel really fortunate about working here is that we have our own internal donor center. We collect 97% of our own blood products. And then, of course, we have our transfusion service and our apheresis service. So I'm very lucky in that I kind of get to do all the aspects of blood banking. But we're kind of small. We're small. We're, a very close-knit team. And I got a call on March 31st. Now, sorry, I'll back up. The FDA issued an investigation into drug protocol for convalescent plasma on March 27th. So this was hot off the presses. That Friday, they issued the ability to collect convalescent plasma. On March 31st, which was the following Tuesday, I got a call from my colleague, Dr. Mary Berg, who I'm sure many of you know, who works over at the university. And she said that they had a patient whose family was just insistent that he get convalescent plasma. And the local supplier for the university, we don't supply the university, but the local supplier for the university was working very hard to get convalescent plasma up and running, but they're a national organization, so they just weren't up and running yet. They expected it to be a week or 2 before they were able to start collections. And so I looked at the guidelines, I looked through the draft, I looked at my team, I talked to Micro, and we all felt like we could figure this out. And so we did manage it. We had our first, we were able to call a person who had recently recovered from COVID-19 and had actually just happened to call us and say, hey, I had COVID-19, when can I donate blood again? So we reached out to that donor. That donor was able to come in the same day. We have in-house PCR for the testing, which was required at the time. That's since been dropped. And we were able to perform the repeat PCR to confirm that she was no longer shedding virus. We were able to get everything set up, and we were able to collect convalescent plasma on her that same day. And in the meantime, the blood bank was furiously creating the label and putting the ISBT code. Everyone really was just all hands on deck to make this happen. So as I said, we had the first convalescent plasma in hand that night. We then had to send do our testing. So we send our testing to CTS, we send out our testing. And then as soon as we got those results in, my supervisor of the blood bank drove in at 2:00 in the morning to label that unit and get it over to the hospital. So 2:00, or very early in the morning on April 2nd, this gentleman received the first convalescent plasma in Colorado. And I'll be able to tell you what happened to him at the end of the presentation. And this is this is public information if you want to look for it. This was just a lovely article that was done by one of the staff writers for the university. Next slide, please. So let's talk a little bit about eligibility for convalescent plasma, which hasn't changed that much, although there have been a lot of changes over the past few months. It seems like every time we figure out the next change, a new one comes down the pipeline. So as of May 1st, the convalescent plasma requirements for donors were that they must have a confirmed positive test for COVID-19, and it was either antibody or PCR. The original requirement, the one that we were working on for that first collection, required PCR. The antibody wasn't eligible yet, but it now is eligible to be based on antibody, a positive antibody test. The donor has to be symptom-free for 14 days. And originally they were required to have a repeat nasopharyngeal-based PCR test to prove they were no longer shedding virus. And the reason for this was to make sure that you didn't have someone who was potentially still contagious walking into the donor center and potentially infecting more people. There's been some studies since then that we figured out that this viral particle shedding isn't really infectious material, so that particular aspect has been dropped. But initially, that was a particularly big hurdle for some of the larger centers to manage because they didn't have in-house PCR. I was fortunate with Children's that we do have in-house PCRs, and that's one of the reasons we're able to do this. And then they have to, of course, meet all of our blood donor eligibility criteria, which I'm sure all of you are aware recently got easier. I will say the travel history is really easy for my donor collection staff right now because nobody's gone anywhere in 3 months. It's always no, I haven't traveled in 3 months. No one's left the country. People have barely left the state. But there's now a 3-month deferral, so that does make the criteria a little bit easier. And we still have to defer for HLA antibodies. And then if available, so this is the wording in the guidance as of May 1st, and that was if available, neutralizing antibody titers of greater than 1 to 80, and the ideal is greater than 1 to 160. So when we first started collecting convalescent plasma, pretty much very few people there. I don't know of anywhere that had an antibody test up and running yet. We did not have an antibody test up and running yet. We were developing one, but we did not have one in-house. But at the time, the criteria let us transfuse these units presumptively because they'd had their positive PCR. So that's what we did initially, but we saved a sample on every one and we're able to retroactively test everyone at a later point. Next slide, please. So as of when I wrote this presentation, which is now a couple of weeks ago, these are our numbers. So we collected a total of 207 blood donors over the next 3 months. And we collected a total of 512 units. And as you can see from this graph, beginning of April to the middle of May, we really were collecting a lot. We actually managed to peak at collecting somewhere around 20 units in a day at one point. And that was because we were really trying to do our best to support the community while the other blood centers kind of got up and running with their convalescent plasma collections. And I will tell you, we could not keep this stuff on the shelf. I had a waiting list of 2 to 3 days for people who wanted to get convalescent plasma. I'd get their request, I'd put them in the queue. We had to prioritize a little bit for ABO, but we were just collecting as quickly as we could, and we could not keep it on the shelf. Next slide, please. So we learned a lot of things as we went through this process. One of the early events that happened was we had a donor who came through, got his second PCR test. Those are not comfortable, by the way. I don't know if you've had one, but they do feel like, it feels like a lit match is poking your brain. I had to have one, and yeah, they're not fun. So volunteering to do a second one for this makes these donors like extra angelic. But so this donor came through, got a second PCR test, and then was ineligible due to medication. The donor was taking Propecia for hair loss. And so because of that, we felt that we didn't want to invest all of this energy and have someone come in and not be eligible. So we implemented a full pre-screen. We had my apheresis nursing staff were not very busy at this time because of the hospital closures. So they volunteered to pre-screen donors. And so they went through every single question in the DHQ to make sure somebody was eligible before they would be scheduled for convalescent plasma. We had multiple donors that were repeat positive for the COVID-19 PCR test when that was still implemented. So for example, we had one donor who for some reason got a PCR test somewhere else. After day 28, you no longer had to do the PCR test. So between 14 and 28, you needed it. And so we had a donor who was scheduled on day 29, and we weren't going to have them do the in-house PCR. But for some reason, they got this test somewhere else. And then they called us and said, oh, my test is positive. So then we weren't really sure what to do because after day 28, he didn't even need to be tested. And then, of course, there's the question of was there a danger to staff? We ended up writing that one up as a variance, but that one was a challenge. We had a donor from Vail, which is at 8,000 feet, who had a hematocrit that was too high for the instrument. So in Denver, because we're at altitude, we all kind of have a general higher level of hemoglobin than you would have at sea level, right? Because we need the extra red cells to help us pull more oxygen out of the atmosphere. There's about 23% less oxygen in Denver, in the air in Denver, than there is in at sea level. And so at Vail, some people will have a really high hematocrit. And this gentleman had a hematocrit, I think it was around 18, and the system kept rejecting it. So this picture is actually his convalescent plasma, because I said, no, we're going to figure this out. We're still going to collect him. So we did collect him, and we wrote a variance for this one too. We just were very careful about who this particular unit went to because it was so bloody. And it turned out, initially I had a variance to do a different protocol for this, but it turned out that there was actually a software error in the equipment we were using. And once we had the software error fixed, it was able to accept and adjust for much higher hematocrits. So that problem went away. But initially we had that problem, and we had to figure things out. And then we had multiple changes to requirements through the FDA. As I mentioned before, we have had a number of changes come through, and every single time it was, fortunately, the first few made things easier, but we certainly had to scramble a little bit sometimes to figure out which changes applied to us, how we wanted to change things. We, for example, decided not to implement accepting donors based on an antibody test. We have still been requiring a positive PCR. We decided not to make that change. And there have been some other changes along the way. And then the last thing that's been a big challenge, and you've probably seen some news articles and literature coming out about this one as well, is the antibodies goes away. So with our donor antibody testing, we found about 22% of our donors were negative on initial donation. Now remember, these donors have been pretty freshly recovered from COVID-19. And I would say the range on this was, the earliest person who was negative was 17 days after recovery. And this particular analysis went up to about 40 days. So of course we can't ethically transfuse a unit once we know that it's antibody negative. So we had to decide how we were going to manage having to dispose of these units. So that's been part of our process, and I can talk about that a little bit more in a minute. Next slide, please. All right, so what are our next steps? So by the way, I don't know if any of you recognize this gentleman. It's a little hard because he's wearing a mask, which is appropriate. But this is Colton Underwood. He is one of the bachelors, and he is one of the, he was a football player. And he is the nicest guy. I talked to him for a little while he was donating his plasma, but he was so excited to come give us this big fat 4-unit convalescent plasma. He told me now he could compare himself to Tom Hanks for giving his convalescent plasma. But so he was really excited, and you can see that this particular clip I took was 40,000 likes, but this one went up to over 120,000 likes for this particular post that he made on Instagram. So that was a lot of fun. So we did get a couple of celebrity donations through all of this. As I was saying, we had to redesign our donor process. So we needed to maximize high titer product, and we wanted to minimize ineligible products because we just have to throw them away. There wasn't really anything else we could do. I want to mention that the FDA did say that we could collect convalescent plasma donors more frequently than infrequent plasma traditionally is. So infrequent plasma is 28 days. And the FDA said that at medical director discretion, we could collect more frequently. So I reduced the window to 7 days. Well, that means that if I have a plasma that's negative, I can't convert it to regular plasma. It's not eligible for that. So we essentially just had to throw out these units, which is really unfortunate. So what we did was we actually decided to do a two-step process. So right now we have our donor come in, we pre-screen them for their blood type, their antibody levels, and their HLA, if they're a woman who's had a history of pregnancy. And then we have them come back if they're positive and appropriate with the other criteria. If they're positive for antibodies and appropriate for the other criteria, we have them come back within 7 days. And then we go ahead and collect them. And by doing this, I feel like we are minimizing the number of units that we are ineligible for donation. We are using an in-house developed ELISA test that's using two manufacturers. It's one of them is Urami for us. It's been we've developed a signal to cutoff ratio that was equivalent to a titer of 1 to 100. And I can talk more at the end about what is coming in the future with that. But so we developed this in-house test. And then we changed some other things. So we now have an online pre-screen, so the donor is able to completely fill out the donor health questionnaire online ahead of time. That saves a lot of time as opposed to having someone to be on the phone manually. And then we've also had some challenges with reimbursement. Initially, we set up contracts with all of the hospitals that we exported to based on essentially our bare minimum cost for collecting per unit. Now we do have BARDA with Operation Warp Speed, which I'm sure you've heard about in the news, that is providing some reimbursement for convalescent plasma. So we've been working with that. And then we've also wanted to make sure that as we collect this, we are embracing opportunities for potential research to kind of answer a lot of questions that have come up along the way. So I am looking at doing some surveys of donors for symptoms and comparisons. We are currently testing a lot of our blood donors for prevalence studies and a few other things. And then, of course, we want to develop a stockpile, and that's kind of the goal with Operation Warp Speed, which I mentioned before. So right now, we actually have about 50 units in inventory. It was 100 units when I prepared this PowerPoint. And the plan for U.S. stockpiling is in development. We ideally would like to collect 1,000 units. I'm not sure if we'll get there, but we are trying. So hopefully we can still contribute somewhat significantly to the national blood supply. We're really small, right? Our whole blood donation, like with platelets and red cells, is about 12,000 a year. So for us, collecting 1,000 units of convalescent plasma is a lot. I mean, but it's really small change compared to Vitalant University and the Red Cross. But we do what we can. Every little bit helps. Next slide, please. All right, I just wanted to provide this. One of our biggest questions from hospitals has been a label, the question about the ISPT codes and the ISPT label. So I'm literally providing you a picture of the label, at least the label as of the last FDA guidance. The label will undoubtedly change with the EUA that just came out. But for the moment, this is the current label that is needed for convalescent plasma. We have shipped to 17 different hospitals in the Colorado area. We have shared plasma with the blood bank in San Diego, and we have shared plasma with Versity. We sent some to Chicago, and we also sent plasma to so where's the other place? Utah. We sent some to some colleagues in Utah. So we have shipped over state lines. Now we're actually a registered FDA facility. We're not a licensed FDA facility. So normally we can't ship across state lines, but because this is an EUA or an EAP, we are able to ship across state lines because there's an exception for that. So I can't send normal plasma or regular red blood cells across state lines, but I can send convalescent plasma. So that's been fortunate because we've been able to help out some other areas. Next slide, please. Right, so most of the interest in, most of the research that's been going on for convalescent plasma has been on the recipient. So it was a little bit difficult to find really donor-specific related studies, but I wanted to highlight just a couple. Also, this is a picture I took from one of our convalescent plasma donors. I just thought it was really cool with her tattoo, which is protection, and then her blood circulating around it. As I said, the focus has been on recipient outcomes. One of the studies that looked at donors was a case report published in the Journal of Pathology of the first 25 recipients of convalescent plasma from Houston, and that suggested benefit but had no controls. And they compared the strain of the antibody in the donors to the strain in the recipients, and they found no significant differences. And this suggested that there are not two different strains. So there was some concern that maybe there was a mild disease strain and a more severe disease strain, but it does not appear that that is the case, at least not for the level of infectivity or the level of symptoms. There was a study that looked at serological reactivity evaluated in 436 individuals with COVID-19 history. 256 were confirmed COVID. And of these donors, 99% had measurable antibody response, 88% had neutralizing antibodies. And so that may be significant because you might have a positive antibody test, but that doesn't necessarily mean you have neutralizing antibodies, or you may not have neutralizing antibodies at the same level. So these are things that we'll be needing to look into more in the future. And then the authors noted that antibody levels decreased over the next 3 months, which is consistent with what I saw with our donors. And then there was an analysis of 125 convalescent plasma donors. 80% had detectable neutralizing antibody titers. And they noted that male sex, older age, and hospitalization were correlated with increased antibody levels. And they also noted that neutralizing antibody titers decreased over time more dramatically than overall antibody response. So that correlates well with the previous study that I just mentioned. And again, raises the issue that the level of IgG, if you're using an ELISA-based platform, may not correlate to the level of neutralization antibodies. So it's going to be something that we're going to need to look at as we go along. Next slide, please. So I showed you the picture of that gentleman at the very beginning. I'm happy to tell you that after 34 days on a ventilator, he was able to get up and go wave to his family out the window for the first time in over a month. And he's actually doing really well. I do occasionally hear from his family, and he's been very fortunate, hasn't had any sequelae. So we're really, really happy that this particular gentleman has done so well. Next slide, please. And that is everything I wanted to say for now. And I'd be happy to answer any questions. I believe Dr. Bryant is going to field any questions. Thank you very much, everyone, for your attention. You're on mute.
There we go. Got to unmute. All right. Hello. Thank you very much, Cal. That was so very interesting. I appreciate you telling us all about what you're doing in Colorado. We do have some questions that's come across. The first one is, what changes does your facility plan to make with the new EUA that was just released by the FDA?
Oh, it's such a loaded question, because I think that there's still a lot of confusion about exactly what needs to happen. We do currently have the Abbott in-house, and I believe that they are reaching out to the FDA to be considered a option for essentially being able to label the convalescent plasma as high titer. So the EUA has established that the antibody levels can either be high titer, and they've authorized one particular platform to label it with high titer, and then anything that is not tested on that platform and meeting that established signal to cutoff ratio has to be labeled as low titer. So right now, all of our units are going to have to be labeled as low titer, unless the in-house Abbott that we do have available becomes approved, in which case we would label according to what the EUA comes out as for that particular platform. As far as overall collections. I am looking to transition. As I mentioned before, we are currently still requiring a PCR test in order to be able to bring in a donor. With these changes, I do feel more confident with the amount of research out there that the antibody test is going to really prove that antibodies are there. I was very concerned initially about a high false positive rate based on a single test. So we will be probably start collecting people who have an antibody positive test, and then test them on our current platform. And I think most likely we'll test them on 2 platforms so that we'll have 2 confirmed tests that antibodies exist, even though only one of them will likely be FDA approved. And we're still trying to recruit donors. There's a lot of challenges with trying to get donors in right now. The Colorado economy is doing pretty okay, so people at the moment seem to have forgotten COVID exists. But I'm hoping that talks like this will help them to remember that we still have a need.
Okay, very good. We have a question. What dosage are you using for convalescent plasma for pediatric patients?
That's a good question. So we established that we were going to use, I believe it was 15 mils per kilogram, which is a very high dose for small children, but we haven't actually had to implement it yet. All of the patients that we have transfused in-house have been essentially adult-sized. And so with that, we were going with the kind of initial protocol that the university was using, which was 2 units.
Okay. Are you using type-specific plasma or just type-compatible?
Type-compatible.
Okay. All right.
At the very beginning, we were doing titers on our plasma so that if the plasma that was available wasn't type compatible, for example, a B to an A, we were doing the titers to try to make sure that we could at least transfuse it safely. And there were a couple of people who did get type incompatible plasma through that mechanism. But since then, it hasn't really been necessary.
Okay. All right. And one last question. Have requests for convalescent plasma increased? And do you expect them to increase with the news media and the and information that's now out there to the lay public?
Well, right now, our local blood supplier who supplies the university and a lot of the other large adult facilities in the area has been able to ramp up their collection. And so most of the hospitals have been predominantly going to them. We get a request for about 2 or 3 units a week right now, so it's not very much. I do think that with the interest in the media, especially depending on which way it goes, because there's been some negative media attention too, and with whatever we don't know might be coming in the fall, I am trying to prepare for another surge of requests. But we are trying to partner very help them since they do ship out of state, and they can actually take our plasma and then ship it out of state, which is a nice partnership.
Okay. Well, thank you so very much. We enjoyed your presentation.
Thank you so much for inviting me.
All right. So now it's time for Dr. Claudia Cohn. Dr. Cohn is the associate professor at the University of Minnesota, where she's the medical director of the blood bank and the director of the HLA laboratory. She is also the associate director of the clinical laboratories, medical director of the Boaton Lab, and the medical director for the Clinical and Translational Science Institute. Dr. Cohen earned her PhD degree in immunology and infectious disease from Johns Hopkins University and was an assistant professor of medicine at Tulane University before getting her medical degree at LSU Medical Center in New Orleans. She started her pathology residency at Charity Hospital, and since we've been chasing or running from hurricanes recently, I want to say that she has the distinction of performing the last autopsy at Charity Hospital as Hurricane Katrina was rolling in. She completed the rest of her residency in New York and did her fellowship at UCSF. Dr. Cohen is the Chief Medical Officer for the AABB, the Editor-in-Chief of the AABB Technical Manual. She also serves as the Associate Editor of the ISBT Science Series, which is dedicated to publishing transfusion medicine work in resource-limited countries. Please welcome Dr. Claudia Cohen.
Thank you so much, Barbara, for that very kind introduction. And thank you to the South Central Association of Blood Banks, my favorite acronym in the blood banking world, for inviting me to give this talk today on long-term blood shortages. How can your hospital respond? Next slide, please. I speak well of the AABB in a couple of places in this talk, and so I want to disclose, as Barbara said, I'm CMO of the AABB. Next slide, please. So this talk was originally given, or part of this talk was originally given at the AABB webinars back in April. And I developed these learning objectives at that time: understand the impact of COVID-19 on the blood supply, understand the implications for patient blood management to reduce blood demand, and describe how we can balance supply and demand during this pandemic. They haven't changed that much, though, since this talk was made originally in April. Next slide, please. So we've been living, breathing, eating, everything with this COVID-19 pandemic since probably mid-February or so, and it has changed how we do just about everything we do. Next slide, please. So it's not surprising that it also has had an effect on the blood supply. This is a slide, or these data come from one blood center in the southern region of this country. And on the y-axis are the number of units that they collected. On the x-axis is time from January to June. And you can see in blue are the units collected, and in orange is the demand from their hospital customers. And it's been a roller coaster as social distancing took effect here, and we see a plunge in the blood supply, and then the Surgeon General called for more blood, and the ABC and national surge in altruism as donors just poured out and brought us more blood than we needed, because at the same time, elective surgeries were being canceled and the demand went down. Next slide, please. So although we're well into the pandemic now and the blood supply has stabilized significantly, in the AABB survey to hospital members that comes out on a weekly basis, we found in week 20, which was probably the beginning of August, that 23% of respondents said that they had been alerted by their blood centers that there still were problems meeting their needs based on the blood inventory available. Next slide, please. So in mid-February, late February, we began to see the writing on the wall at our hospital, and we thought that it would be wise to develop a long-term blood shortage plan. We had contingency plans in place for when our blood supplier told us there might be a 12-hour or even a 24-hour delay in being able to get you your full orders. But this seemed to be an entirely different scenario, and it called for different measures. So we decided to create a 3-phase plan with implementing different steps, greater austerity measures, depending on whether it's a mild shortage, moderate shortage, or critical shortage based on the inventory available and the demand at our hospital. Next slide, please. So we spent a lot of time coming up with these very precise definitions of what a mild, moderate, and critical shortage is. However, what I found over time was that these lines really were blurred. For one, my blood bank manager is extremely, has a lot of experience, and she was able to look at the amount of blood that we had in inventory at the hospital, call over to the blood supplier to find out how much they have on the shelf, look at our OR schedule, and just sort of give a thumbnail. This is roughly a moderate shortage today. It looks like we might be in a mild shortage the rest of the week, etc. So although we had these definitions, and you can possibly use these definitions in your hospital, we didn't depend on them very much. In addition, we made measures to meet all of these different conditions, but once again, the lines were a little blurred, and I'll get into that later. Next slide, please. So when we were still in a mild shortage is when we made this plan, and the first thing we did was we developed the plan and we discussed it with leadership, not only the CMO of the hospital and other leaders in the hospital administration, but also the leaders of different departments that use a lot of blood. We needed their buy-in because their patients were going to be affected. We also worked very closely with our blood supplier. We asked for daily inventory checks, both on the local and national level, so that we would know we are in the Midwest, which is a mass exporter of blood to the rest of the country. So we might have a lot on our shelf, but if the coasts were in short supply, that might have a ripple effect on the inventory in the Midwest by the next day as blood is shipped off to different areas of the country. We also made postings in our electronic medical record so that every day clinical providers could see what sort of code we were in. Code green meant roughly business as usual with a little bit of tightening of the belt. Code red meant it's severe. We're going to start having to say no to many of your blood orders. Next slide, please. So these are some of the measures that we would put into place as we moved into different phases in the plan. If it was a mild shortage, then patients that came in for red cell exchanges for sickle cell disease, we decided, based on ASH guidelines, to reevaluate the indications, therapeutic goals, and procedural parameters of the red cell exchange program. For instance, we could consider temporarily transitioning some patients from a full red cell exchange to either simple transfusions or partial manual exchanges. These decisions were made in consultation with the hematology doctors covering these patients, but we made significant exceptions if the patient was an iron overload, they had evidence of end organ damage, or they presented with priapism. If any of these three were in place, we did not put this measure into effect because the physicians, the clinicians felt that it was not appropriate for these patients. We also reevaluated the hemoglobin S percentage target from less than 30%, which is our norm, to less than 50% on an individual patient basis, again, in consultation with the hematologist, because that would allow us to extend our blood supply, use fewer units in a red cell exchange. Next slide, please. This shows the URL for the ASH guidelines that were published in conjunction with the Sickle Cell Disease Association of America when the shortage of blood came out. And so this is available to you if you have this slide set. Next slide, please. Never in short supply for us. However, we made arrangements in case it was. We use a lot of our plasma for therapeutic apheresis. So we already try to use albumin whenever it's possible, but one disease for which you always need to use plasma is TTP, thrombotic thrombocytopenic purpura, for which you generally do a plasma exchange daily, on a daily basis. So there is literature out there that says you can use a 1-to-1 ratio of plasma to albumin, and that is perfectly safe for patients. Just to be conservative, because we weren't in a shortage, I went with using full plasma the first 2 days, and if the patient appeared to be responding well to the treatment, their platelet count was going up, their LDH was going down, I would start switching to the 1-to-1 ratio. Next slide, please. When I gave this talk originally in April, it was with Steve Frank, who is an anesthesiologist at Hopkins and I think well known in our community for his patient blood management work. And he had an entire talk about patient blood management efforts in the OR and the peri-op environment. I can't go through his talk, but I thought it was such a valuable talk. I just wanted to include this slide. I'm not going to go through this, but we do most of these measures at our hospital already. We made sure that they were in place during the shortage because it really helps amazingly in preserving units by implementing these patient blood management measures. Next slide, please. Okay, we're shifting from the measures implemented for a mild shortage to those implemented for a moderate shortage. And I'd like to say that as we move from mild to moderate to critical shortages, the measures we recommend are farther and farther away from guidelines. So whenever you consider any of these recommendations, consider them carefully. Consider them with a lot of common sense in mind and document everything you do carefully because you're getting away from standard of practice here. But in some cases, you might need to do that if the blood is in short supply. So the first measure we recommended was to cancel elective surgeries. Of course, we recommended that before the Surgeon General went ahead and did that, but he did that for other reasons. He did that because there was a shortage of PPE, a shortage of ICU beds. But as it happened, it helped with the blood supply significantly. For some hospitals, it reduced the amount of blood used 30 to 50%. Postpone non-urgent stem cell transplants. It's kind of hard to couple the words non-urgent and stem cell transplant together because these patients are often quite sick. But we did do this in our hospital because we were really worried that we wouldn't have enough blood, and these patients use a remarkable amount of blood. prospectively audit all red blood cell and platelet orders. So what we did is we put our guidelines for red blood cell and platelet orders next to the computer where the orders came in, and the technologists in the blood bank reviewed every single order and tried to decide whether it was appropriate to fill these orders based on what was available at the time. I had always wanted to put this measure into effect, and in fact, we like it so much, and it hasn't been that much of an onus on our techs. We now continue with this, even though we're no longer in a shortage. Next slide, please. Other things you could do in a moderate shortage. If platelets are in short supply, of course, if you have VRAX, you can extend the shortage of platelets to from 5 days to 7 days. However, if you don't have VRAX or other point of release tests available to you, they're also called rapid test devices. As a medical director, they may extend the out date of platelets from 5 days to 7 days based on critical need. So to do that, you have to document that there is critical need for an extended out date in a way that is linked with the specific component and the specific patient. Now, the passport study run about 12 or 13 years ago now showed clearly that if you that platelets that were stored for 7 days have a greater risk of bacterial contamination than those that are stored for 5 days. So you are exposing your patient to a greater level of risk. So it is wise, if you do this without a point of release test available to you, to call the clinician and tell them that you're doing this. Maybe order prophylactic antibiotic just in case to protect the patient, or watch the patient with extra care after this platelet transfusion. If you plan on implementing this for multiple platelet units, then consider writing an SOP and maintaining a log of components so that you have everything documented and it is easy to do. Also, consider adding a note to the patient's chart. Again, you need to document everything, and you need to balance the risk with the benefit. If the risk is you're not going to have a platelet available to a patient because they're all outdating, then it is probably worth it. If the risk that the patient is going to go into septic shock and the patient can't withstand that extra insult to their system because of a bolus of bacteria, that's probably a risk you don't want to take. You have to look at the patient, look at your inventory, and decide what to do. Next slide, please. There are ways to reduce wastage that also bend the rules somewhat, and we use this in a moderate shortage. Red cells are supposed to be maintained at a certain storage temperature when they leave the controlled environment of the blood bank, if they're in a cooler. We all know that sometimes the ice runs out of the cooler, or they're taken out of the cooler and they're placed on the bench in the operating room, and they're not held at exact temperature. If it does have temperature, you could consider just touching that unit. If it's still cool to the touch, chances are you're safe. And if you need that blood badly, you can return it into inventory so long as you document this. If platelets are returned on ice, that's another time when you can consider returning them to inventory. Cold stored platelets are allowed to be used with a variance. They need to be stored for just 3 days. Storing them in the cold tends to activate the platelets in the bag, so there's a greater thrombotic risk to the patient. If the platelets are stored in plasma, the tendency to form a clot and see that visible clot in the bag is much greater than if the platelets are stored in PAS. So if you have the platelets on ice and you hold them up to the light and there are a lot of clots, you probably should throw that bag out. If they're stored in PAS or you don't see any clots in the bag, you can consider using them. It's better to use them for trauma patients, because if the patients are bleeding actively, they might benefit rather from those pre-activated platelets that are going to form a clot more quickly. Again, common sense, good judgment, document everything if you're going outside these guidelines. Next slide, please. Another way to reduce wastage that is definitely outside of guidelines, you can ask to continue a transfusion after a transfusion reaction has been reported. So ask the nurse to halt the transfusion, call into the blood bank, and talk about what the symptoms are, talk about how the patient is doing. What I like to do is eliminate the two most dangerous kinds of transfusion reaction, an acute hemolytic reaction or a septic reaction. So I ask, is there any evidence of hemolysis? If they have a Foley in and you can see that the urine has turned pink, well, stop the transfusion immediately and return the bag. How high is the fever? Does the patient have a recent history of spiking temperatures? We have a lot of hem-onc patients in our hospital that spike a neutropenic fever every hour on the hour. So it's a good chance that a fever that is spiked during a transfusion is simply due to underlying disease. So consider the entire patient while you're trying to decide whether this is a true transfusion reaction. Is the patient already on broad spectrum antibiotics so you can worry less about a septic transfusion reaction? Has there been a sudden drop in blood pressure? Those scare me more than a rise in temperature. And so if I hear about a sudden drop in blood pressure, I'm going to tell the nurse, stop, this is probably a real transfusion reaction. Doesn't matter, let's waste that unit. How much the unit was used, how much does the patient need? If the patient really only needed a little bit of the unit to stabilize, they may have received enough already and you could stop that transfusion and throw the bag out. But in other cases, the patient needs that full unit and you might want to continue if these signs and symptoms are mild. Next slide, please. So if the medical director determines that this is a mild febrile non-hemolytic transfusion reaction or underlying disease, you can consider continuing the transfusion. Again, this is my mantra, use common sense and document everything. Next slide, please. Now we're moving way beyond guidelines. We're moving into an area where there's a severe shortage and patients either get that unit or they don't get that unit because it's not on the shelf. So consider lowering the red blood cell transfusion threshold below 7. Some hospitals I know in the beginning of the shortage use 6.5, someone even lower. So this would need to be done in asymptomatic stable, non-bleeding patients. You're in an area where there's no evidence developed by a randomized controlled trial, but of course, if a patient has slowly gone down to a lower hemoglobin, they probably can withstand this. You have to consider the patient when you're considering whether to go beyond the 7 threshold. Platelets, you can consider lowering the platelet threshold for prophylactic transfusions to less than 10,000, or consider reducing prophylactic platelet transfusions for stable patients. I told you in the beginning that we met with leadership in the hospital to discuss all of these changes and get buy-in. This is one place where my hem-onc docs put their foot down. They said they would not allow it because it's a lot easier to keep a patient from bleeding by giving prophylactic platelet transfusions than it is to stop bleeding once it has begun. So they asked me to not implement this unless things got really, really bad. Next slide, please. I think I'm frozen. Do you see the next slide? Split units? Okay, here we go. So one of the things we did instead was we considered splitting units. When they called for a full red cell or full platelet, we would give them half a unit instead to preserve inventory. We have a sterile docking system to do this, of course, and a red blood cell unit, the mother and daughter bag both retain the original outdate, but for platelet units, the daughter bag is good for only 24 hours. The mother bag maintains the original outdate. So if a patient needed a unit, we would send them half a unit if necessary. And then if they still needed more blood or red blood cells or platelets afterwards, we'd give them the other half of that unit. Next slide, please. High blood use procedures. We put an algorithm in place so that before every liver transplant, every spine case, every big blood case, the surgeons and the anesthesiologist and the blood banker on call would meet, and I would ask the surgeon to tell me, how much blood do you think you're going to need? I need 40 units. I would go to my blood center and say, I think we need 60 units for this procedure. Do you think you have enough? If the blood center could tell me that they had 20 units above that even, then I was willing to go forward with the procedure. If the blood center told me, we're barely going to have enough, or if we give you blood for this patient, we're not going to have enough for our other hospitals or for other patients at your hospitals, I would go back to the surgeon and tell them that, and the procedure would unfortunately be scrubbed. Or we would try and search in a wider region to get blood from other blood centers for that patient. It depends on the patient, of course. We communicated these limits clearly to the surgical team. We also would discuss using things such as cell saver or acute normovolemic hemodilution to save on blood further. Next slide, please. Massive transfusion protocols. This is the sort of thing that really makes me nervous because you never know how high they're going to go. So if there's a severe shortage and you're really worried, you can consider placing an upper limit on the number of components available and stop there. It's a difficult rule to put into place. It's an even more difficult rule to enforce, but you might have to do that for the better good of other patients at the hospital that might need the blood. Next slide, please. There is a lot of ethically dodgy things with implementing these guidelines, and so we consulted with the Minnesota Ethical Society. They convened a special panel statewide just because of COVID. They oversee how remdesivir was allocated, and they made suggestions as to how blood should be allocated in the case of the shortage. Now, I'm running out of time, and I don't want to take away time for questions, so I am simply making these slides available. Next slide, please. This was an algorithm we developed with the Ethical Society. The TTT referred to is from Johns Hopkins. They named it the Transfusion Triage Team. It would assemble quickly and run through this algorithm to decide whether a patient should receive a unit of blood if there was a critical shortage. We never had to implement this, by the way. Next slide, please. And the Minnesota Ethical Society also developed this point system for us. And so depending on the patient's need and their underlying conditions, they would get points. And depending on the level of shortage, we would say, if you get 20 points today, everyone above 20 could get a blood unit. If the shortage becomes more severe, we might move it up to 30 or 40, etc. The number of points would be made, or the threshold for points was based on the level of shortage. Next slide, please. So in conclusion, we developed a phased plan that is responsive to the level of shortage and the level of need in the hospital. Clear communication is needed. Difficult decisions may have to be made in a shortage, but you need to apply common sense and think outside the box. And for all of us who are so sick of COVID, this too shall pass. Next slide, please. My coworker put this on her doorway soon after the COVID crisis began. It's from the Ring series. I wish it need not have happened in my time, said Frodo. So do I, said Gandalf, and so do all who live to see such times. But that is not for them to decide. All we have to decide is what to do with the time that is given us. So thank you for your time, and I welcome your questions.
Okay, thank you, Dr. Cohen. I appreciate this presentation. I think a lot of times we're faced with these decisions and wonder what would we really do. And some of this we talk about behind closed doors and think that nobody else is really thinking this stuff. How low would we drop the hemoglobins and would we extend product usage? But we know that we would in an emergency. So it's great to see this presentation and to have a discussion on this. I'm just going to ask one quick question. How much of this have you needed to implement? Now that maybe that you're back up and running with elective surgeries, what does the forecast look like for y'all?
So we implemented only a very little bit of it. We implemented the prospective audits. And as I said in the talk, that was something I always wanted to do anyway. And this seemed like a good opportunity to put something into effect that I was reluctant to do because I'm always reluctant to push the blood bank technologists to do more work because they're always so busy. The other thing we implemented was consulting with the surgeons about how much blood would be used because they use a disproportionate amount of blood on some days. And it was actually a wonderful tool because although I knew them well from having been at the hospital for years, we developed a much tighter relationship. A lot of respect came across in the meetings.
Well,
and the forecast now, we're looking good, although just today,
all right. I don't know if we got cut off there at the last minute, but I'd like to thank both Dr. Annan and Dr. Cohen for your wonderful presentations. Also, I want to just mention a few things very quickly. As we're coming off, we have membership bingo starting at 2:30. At 4:30, we have the Serious Industry Workshop. Are you ready for FDA's bacterial contamination guidance? And at the end of the day, join me at 5:30 for the Engage Virtual Happy Hour. Somehow I got in charge of mixing the drinks. But we will have a virtual DJ as well. I think this will be great, especially since the drinks just showed up here, so I'll be able to make them. So anyway, thank you so much for your participation. And again, thank you to the speakers. They did a wonderful job. All right.
Thank you so much. Bye-bye.